Okay, this is my film evaluation. So a 52-year-old female patient came into Advent Health Daytona Beach with left hip pain on March 3rd, 2021. The patient stated that she went to stand up and her leg gave out and she denied falling. There are no removable artifacts seen on this image, and there is a left marker seen on the lateral side of the anatomy. The part, tube, and bucky are all correctly positioned in this image. The central ray is at the middle of the femoral neck and perpendicular to the IR. However, since this exam was ordered as a trauma, the patient's feet were not turned in case there was a fracture. The part is positioned correctly and proper collimation was used. The technique used for this image was 90 kVp at 10 Mass. This was an adequate technique used for this image, although there is evidence of extra soft tissue from the patient's tummy seen by the femoral head. The technique was appropriate as all anatomy was penetrated adequately. For anatomy, there is the symphysis pubis, the ischial tuberosity, the greater trochanter, the fovea, and the lesser trochanter. And I know this image is adequately positioned because the hip joint, the proximal femur, and the lower portion of the iliac crest are all visible on the image, making it a proper hip. And for the next one, so again, a 52-year-old female patient came into Advent Health Daytona Beach on March 3rd, 2021, complaining of left hip pain. The patient stated she went to stand up and her leg gave out and denied falling. There are no removable artifacts on this image, and a marker was also not seen on this image. So a left marker was annotated by the tech after the image was taken. The part, tube, and bucky were all correctly positioned, and this was a cross table hip image, not a frog leg lateral hip, because after taking the AP image, it was clear to the tech that there was a fracture, and the part is positioned correctly and proper collimation was used. The technique used for this image was 90 kVp at 120 Mass. The technique was greatly increased from the AP because there was a lot of OID in the positioning, as well as having to shoot through other forms of the patient's anatomy in order to get the hip in the image. The technique we used was appropriate, although the positioning could have been a little better as there is some superimposition in the image, but it was not repeatable as the anatomy in question was visualized. And for anatomy for this, we have the femoral head, the femoral neck, the femur, the ischium, and the acetabulum. And this, I know this is an appropriate cross-table hip image as all the anatomy needs to be seen, including the hip joint, the proximal femur, and the lower portion of the crest are all visible in this image.